And our next speaker is Dr. Tracey Wilson from the School of Public Health.
Thanks, Deb. So I'm going to talk to you all about a new project that's starting up. I don't often get the chance to talk to this audience about some of this work, but I think there's an opportunity for collaboration in some of the topic areas that I'm going to talk about. So this is a new project focused on social connectedness. I'll talk about what that means in a moment. Psychiatric and substance use disorders and chronic disease self-management, adherence, engagement, and care, and in this case, viral control for HIV. This study is being done in the Max Wise combined cohort study that I believe Dr. Gustafson provided a little bit of an overview previously. Because these concepts might be, they might not be, they're words we use in everyday language, but in the social sciences, they have pretty specific definitions. So if you'll allow me, I just want to talk a little bit about the difference between social isolation and loneliness as two key indicators of social connection. So we refer to social isolation as more of an objective interpersonal variable that has to do with the amount of people the number of people that you connect with or have interactions with, that you see, that you speak with on a regular basis. Loneliness, on the other hand, is a subjective feeling, and it is toxic. It is associated with pretty much most health outcomes that it's been studied with. Now, the interesting thing about social isolation and loneliness, these really are distinct concepts. The shared variance between the two is only moderate, and it makes a little bit of sense, right? So you can think about people who prefer to be on their own and are completely fine with it, right? And so they may prefer solitude. They're not lonely being by themselves, whereas loneliness can occur even when you're surrounded by many different people. So that's one important distinction to make. About 1/3 of adults in studies that have looked at this have reported, well, adults 45 and older have reported feeling lonely at some point in their lives. Interestingly, and I think this is a myth that we have, and I find it comforting as I think about getting older, maybe some of you also do, even though social isolation increases in old age, loneliness does not. And in fact, feelings of loneliness, we're really concerned right now, the data are showing with COVID, which is one focus of what I'm presenting, is that younger people are really suffering from loneliness during COVID, and that's where we're seeing a lot of the depression, substance use, and suicide. There's an increasing burden of social isolation and loneliness in COVID. We're all talking about it, and maybe some of you saw the New York Times article in the past week that talked about loneliness and social isolation and health impacts in COVID. And persons living with HIV and other stigmatized conditions have a much higher increase of impaired social connection. So many of us have talked about, well, we've all talked about, I think, these issues in our lives, but thinking about what we're seeing in the data, thinking about our students, thinking about the populations that we serve at Downstate, I started looking around to see what kind of interventions exist to help reduce loneliness. And what I found was a really robust literature on predictors of social isolation and outcomes associated with loneliness. And just to go over a few of these, there seems to be some genetic association with loneliness and personality, of course, introversion and neuroticism, but not as strongly as I think a moderate relationship. Many of us are talking about social connection now as a social determinant of health. In other words, social isolation and loneliness seems to be socially patterned, right? So depending on culture, socioeconomic status, physical and mental health issues that are stigmatized, life events and trauma, and actually the way society is structured, living in rural versus more urbanized settings, these things that are determined by humans actually seem to be accounting for a lot of the variation in social isolation and loneliness. And loneliness is increasingly being talked about as a sort of newer social determinant of health that we're called upon in public health to really be thinking about. There's really, really robust literature showing associations between one or the other of these indicators. I don't need to go through all of them, although I'll be talking about substance use and engagement in care and mental health in a moment. But when I look through the literature, and our group looked through it, there have been several meta-analyses, really robust reviews, and in late 2020, an article that summarized them in the British Medical Journal, a consensus statement on loneliness. It turns out we really don't know what to do about it, and so there aren't interventions. There's not clear policy implications, social behavioral interventions that we can clearly point to that can either prevent disconnections in social connections or repair impaired connections.
2 minutes.
That's because this literature is primarily cross-sectional. It tends to not use the same measures over time. And so thinking about this, we realized that one of the studies we worked on, the Max Wise, actually has the ability to move beyond these cross-sectional studies and help us to determine, I won't say causal, but get a better handle on longitudinal patterns of social isolation, loneliness, through repeated annual assessments. So Jackie Myers, who will be presenting after me, and I recently received funding with our team to look at this issue in the Max Wise study. It turns out sometimes you don't know what's in front of you, but we've had measures of loneliness for at least 10 years in the study. We have annual assessments of loneliness. Many of the determinants and outcomes that I listed on the last slide, so we can look at geographic indicators, neighborhood level indicators through geocoded assessments of population density and a number of other indicators of social connectedness, down to polygenic risk scores that have been shown to be associated with loneliness, substance use, and mental health disorders. We are also able to look, because of this, at interruptions or changes in loneliness and isolation over time in the pre-COVID era and the peri-COVID era, and also see how it affects coping with COVID-related stressors. These are just some preliminary data so that you can really see in the cohort that persons living with HIV in our study have been severely impacted by COVID, and this is already a population in great need. We found that loneliness and some indicators of social isolation are significantly associated with being more strongly impacted by COVID, having losses in socioeconomic sources, becoming homeless, losing health insurance, having difficulty paying for needs. We've also found that loneliness greater changes in loneliness are associated with lifetime histories of psychiatric and substance use disorder. So very quickly, we're going to be looking in over 10 years of data at neighborhood level factors, socially determined health risks, and polygenic risk scores to examine their associations on 10-year patterns of social connections in the study. We'll then be looking at how these patterns of social connection are linked to psychiatric and substance use disorders through regular psychiatric assessments in the cohort that happen annually on engagement in care and adherence and in HIV control. And then we're using a model of community engagement to get both to analyze qualitative data that we'll collect over the course of the data, and then to interpret the findings and hopefully develop some initial modules for intervention development. That's it. I hope we get to talk a little more about it. Thank you.